And now I would request Dr. Rajiv Jauhar, who is the Chief of Cardiology at the Northwell Health System, for his talk in role of FFR in ACS non-culprit lesions. Dr. Rajiv, can you unmute yourself?
Now I'm okay.
Now we can hear you.
Thank you so much. Thank you for the invitation, and thank you for my friend Bashir Hanif, who I've known now for, 23 years. So he gave me the daunting task of giving a talk on complete revascularization. I thought I would give it a common sense approach. Dr. Ong said a lot of the slides that I was going to talk about, but so I'm going to probably speed through this a little quickly. But what lesions are significant and which are not significant? That's probably the most important question. Multivessel disease occurs in about half of the patients with STEMI and in about 70-80% of patients with shock. We know it confers higher risk of death, reinfarction, stent thrombosis, and we know that multiple culprits can be present. Therefore, is treatment of non-culprit vessels beneficial? We know that patients with extra non-infarct-related disease do worse than patients with no other non-infarct-related disease. We know that multivessel disease is associated with worse outcomes following PCI. And, looking at the data over the last several years, it favors complete revascularization. In general, when you look at meta-analyses from Brilakis and others, looking at 90,000 patients, that complete revascularization is better than incomplete revascularization. And we should be learning from our surgical colleagues who always express the need for complete revascularization. Fixing one vessel and not the other doesn't make much sense to me. But our case for not performing multi-vessel PCI is that every PCI for every lesion increases the risks. The longer, more complex procedures, it causes contrast nephropathy. You have to use another guide, additional procedure time, cost, radiation exposure. And really, are non-culprit lesions exaggerated during AMI because of the epinephrine surge we have? We know that FFR has been negative in 40% of lesions when you bring them back. And all of us have seen lesions that we thought were significant during the acute MI, that when we bring the patient back a couple of days later for something else, we find that diag or the other vessel does not look angiographically significant. So, we need to keep it simple. And this is a dilemma that I had a few weeks ago, an acute circumflex infarct, that mid-LAD definitely has a lesion. Is that lesion significant or not? This right lesion is clearly significant. And so we fix the circumflex, we fix the right because that was significant. But what do we do about our LAD? Do we do nothing? Do we do a non-invasive test? Do we bring him back in 1 to 3 months? Do we do it now? Do we do a pre-discharge? Do we do a test on it? What if it was a proximal 90% LAD lesion? Would we have fixed it then? And so, we have to yield to common sense when we do complete revascularization. Do we have enough evidence? Well, if you look at the original data using angiographic basis with PRAMI and culprit, PRAMI did show some benefit, but the reality is that PRAMI was looking at any lesion that was 50%, and I'm sure that nowhere are we treating 50% lesions, or are we ignoring tight lesions? So there's limited applicability there, and we all know that this oculostenotic reflex that we have is undermined by physiology, that what we think is significant when we do physiology is not significant, and vice versa. There are many times I thought that a lesion was not significant angiographically and then did it at FFR or IFR, and it was significant. So clearly there is real-life cardiology, which is the oculostenotic reflex, but the practicality is that to treat these patients, FFR-guided is very important. And the complete acute trial, which which Dr. Ong mentioned a little bit on, showed some significant improvement with FFR-guided complete revascularization. And the question remains whether complete revascularization is the same thing as reasonable complete revascularization. Ideally, imaging-guided revascularization of every ischemic-causing lesion, which may not equate to complete anatomic revascularization, but the risks and benefits must be weighed and applied to the individual patient. Dr. Ong mentioned the BioVasc trial, which said, well, do we complete it during the index procedure, or do we do it within 6 weeks? And since he talked about the trial, I won't bring it up, but it was a non-inferiority trial, and there was no clear superiority with complete staged versus immediate complete revascularization. The only difference was that the number of myocardial infarctions was much higher in the stage group significantly, and the number of unplanned ischemic-driven revascularization was significantly higher in the stage group. So waiting 6 weeks may not have been beneficial in that situation. But again, this is sub-analyses, and it's unclear what that means. So what do? I absolutely consider revascularization, EKG symptoms, hemodynamics don't settle the question. If it's angiographically tight, I do it there and then, or during the admission if I've used a lot of dye. And I have a very low threshold for FFR, IFR. I do not send patients in 2023 for a non-invasive test prior to discharge. So what happened to my patient? The LAD IFR wire during MI? Should we fix this lesion? But we did IFR on this lesion. It was 0.91, so we left it alone. And the patient went home and has been doing well ever since. So my approach with multivessel disease, if there's none, well, we're done. If there is, I'm not going to talk about shock. That was culprit. But if there's no shock and the STEMI is uncomplicated, I hold off and stage. If it's complicated, I will do FFR guided for intermediate lesions, and any lesion above 70%, I will treat according to my belief, which is that this is it's better to treat and complete revascularize patients based on significant angiographic data or intermediate data FFR guided PCI. So where do I stand? I stand probably in the middle between culprit only versus multivessel PCI. And so a common sense approach to lesions and patient care, because I have now become a little scared of my own mortality. I did a CT angio, and I have a coronary score of 0 and really a beautiful LAD. So I thank you all very much for the time, and Dr. Bashir, thank you for giving me 5 minutes to speak on this hot topic. Thank you.
Thank you very much for this lovely talk, and thank you very much for finishing on time.